Here we're looking at a typical cervical vertebrae, and the typical cervical vertebrae are going to run from C3 to C7, which means C1 and C2 must be atypical. So C1 and C2 are not going to be like C3 through 7. So the typical cervical vertebrae is going to have a smaller body. It's going to have a larger spinal canal, because remember, the spinal cord is just starting. It's going to be quite large. At that point, we have a cervical swelling in the spinal cord, and so this needs to be large in order to accommodate that. It's going to have shorter transverse processes, and also, now this is key. Write this down, highlight it, put asterisks by it, stars, whatever. All cervical vertebrae will have transverse foramen. So when you're shown a bunch of vertebrae and you have to tell whether they are cervical, thoracic, or lumbar, if there's a transverse foramen, it is going to be a cervical vertebrae. Even most animal skeletons, it'll tend to be more of a transverse canal, but it will have those markings, because what goes through that transverse foramen is the vertebral artery, a very important artery that has to go to the brain. Okay, so, and there's also a vertebral vein there as well. Yeah, there's the transverse foramen. Okay, and then the spinous process of C2 through C6 is often bifid. Bifid means it's forked. So, as I said, the first and second cervical vertebrae are going to be unique. They're atypical. And the first one is the atlas, and the second is the axis. So C1 is atlas, C2 axis. And here we have the atlas and the axis. Again, how you remember this, C1 is, who's that guy that holds up the world on his shoulders? Atlas. And so this is holding up your world or your globe. So this is where your skull will attach. And it has superior articular facets, and these facets are going to articulate or connect up to the occipital condyles of the skull. Remember, the occipital condyles are on either side of the foramen magnum. So you can see where those condyles would attach or articulate. I hate to say attach because they're not functionally fused or anything. There's movement in there. It's a joint. Okay, so it allows for movement, and then the foramen magnum is the hole that the spinal cord is going to be coming out of and going down through the vertebral foramen. Or, as I said, if we have a whole stack of cervical vertebrae, it'll be the vertebral canal. And so, since we have this attachment right here for the skull where it articulates again, we say that this is called the atlanto-occipital joint. So atlanto-occipital joint. Atlanto for atlas, occipital because the occipital condyles. And if we isolate the movement of this particular joint, it is going to have a nodding movement. And so we say that that's the yes joint. Some other parts that we have here, we have an anterior arch, we have the posterior arch, we have what are called the lateral masses. Lateral masses are actually easier to see if you're looking at it head on. Let's see, we definitely have transverse foramen going through the transverse process. And down here we have the axis. Now it's called the axis because it has this little thing that sticks up that's called the dens or odontoid process. And let's think about that word odontoid. If you go to the dentist, what are they checking out? Okay, dentist. They're checking out your teeth. So dont refers to teeth. Now this thing is going to stick up like a single tooth. And I'll show you a better picture in just a moment. But this odontoid process is going to come up and it's going to articulate with the articular surface for the dens of the axis right here on the atlas. And it's going to look like this. So you can see the dens. You can see where it's attaching to this articular process. And there's going to be hyaline cartilage wherever the bones come together. And so this is going to allow the atlas to rotate back and forth. Okay, so we're going to call that the atlantoaxial joint. And if it goes back and forth, you're saying no. So we say the atlantoaxial joint is your no joint. So the atlanto-occipital joint is your yes joint. The atlantoaxial joint is your no joint. And one thing you might want to notice here is there's a ligament, the transverse ligament, and this keeps the dens in place because if this ligament were to break or if this dens were to break, then the atlas will shear forward and you will slice the spinal cord. This is why after a car accident, and if an ambulance comes, they typically will put a rigid cervical collar on a person who's been injured in a car accident. The main reason they do that is because this dens can snap. And you might be okay, you'll be looking around and maybe you'll bend over to pick something up, and just the weight of your head is enough to shear that broke off dens, and now you're paralyzed from the neck down. Now, we're not just relying on this transverse ligament. There's other ligaments as well. So what we've done is we've cut away all these posterior elements, and we're just looking at this front section from the inside. And so we have what are called the alar ligaments and the cruciform ligaments as well. So there's quite a bit there that are hanging on to the axis, basically, to keep it in place. Okay. Now, one thing to remember, though, in individuals with Down syndrome, these can be weak or even missing, and that's going to create quite a bit of head instability. And so they have to be quite careful that they don't allow for any head injuries where there might be that shearing effect and sever the spinal cord. Looking at an X-ray, we would call this an AP cervical. Now, AP means anterior to posterior. So whenever you see an AP or a PA, it's referring to which way the X-ray beams are going. If they're going from the anterior to the posterior, that's an AP. If we turn the patient around and shoot the X-rays through like the back of the neck, so those X-rays would be going from posterior to anterior, we'd call that a PA. Okay. Typically, we want whatever we're trying to take an X-ray of closest to the X-ray cassette. And so this is an AP. As far as I can tell, it's not really listed here as an AP. This is a very good x-ray, by the way. Now, to count these off, you want to come down and you want to see where the first rib is. This is the first rib. Okay? And the ribs connect up to the thoracics. So since we have a rib connecting to this is going to be a thoracic. So it'll be your T1. So if we go above it, that's going to be our C7. So C7, C6, C5, C4, C3. Okay. Like I said, most cervical AP cervicals are not this sharp or clear. Now, it's been a while since I've shot x-rays. I used to shoot x-rays in my own clinic of my patients, and I know it's come along quite a bit. Back when I shot x-rays, I actually had to develop my own film and everything. Now, of course, it's all done electronically. You don't have to worry about all those chemicals. The cassette captures the image. You plug the cassette into the USB, download the image, and you can enhance the image as you need to in the computer to get a better image. So again, this would be T1, so C7, C6, C5, C4, C3. Okay, one thing that we're concerned about though is C1 and C2, especially if there had been an accident. Now, looking at a lateral view, this is what a normal curve would look like in a lateral view. See, everything is nice in place. Here's the atlas. Here's the dens right here for C2 for the axis. And here's the posterior elements of the atlas. And then, of course, here's the rest of the axis. Okay. So C1, C2, C3, C4, C5, C6, C7. A lot of times the shoulder gets in the way when you're trying to look at C7. So if the patient's not in a lot of pain, you can hand them weights or jugs of water, and that'll pull the shoulders down. Okay, now we do an extension. Now, if you suspect someone has any type of fracture in the neck, you're not going to be doing these extensions and flexions. Again, this is a flexion. Notice in flexion that the cervical spine actually straightens out. Okay, cervical spine actually straightens out. Okay, we still don't have a good view of the dens, though, to see if there's a fracture at all. And so the next x-ray is very important. This is what we call an AP open mouth. So, and it's just like it says. We're shooting it from anterior to posterior. We have the patient's mouth open, and we're directing those x-ray beams right through the mouth. And here you can see the dens. Here you can see the rest of C2, the body. Here's atlas. These are the lateral masses of the atlas. And you can kind of see the arch going over it. This is a difficult x-ray to get. You have to position the head just right. Otherwise, the foramen magnum will overlie the dens. If you get teeth in the way, see how jagged these teeth look? If these teeth are overlaying the atlas, or the dens, I should say, that could look like a fracture. You know, this little rough shadow here could look like a fracture in the dens. So, again, this one takes a bit of practice for all you rad techs out there. Looking at a cadaver dissection, this is what the cervical spine would look like. And you can see the vertebral artery going up through the transverse processes. Looking at a cadaver that's been mid-sagittally sectioned. Again, we can see C1 here. We can see the dens of C2. Here's the rest of C2, C3, C4, C5, C6, C7. And we can see T1, 2, and T3.